Welcome, everyone. This is our bonus talk in the Interpreting Veterinary Literature series. And today we're going deep on meta-analyses. You've already seen forest plots in Talk 2, and we touched on heterogeneity in the pooled diamond. Today, we're pulling back the curtain on the entire meta-analysis process, from how studies are selected, to how results are pooled, to how you spot when a meta-analysis might be misleading you. Meta-analyses sit at the top of the evidence hierarchy, but that doesn't mean they're automatically right. It means they're only as good as the studies they contain and the methods used to combine them. By the end of this talk, you'll know exactly how to evaluate one. Let's get into it. Here's our roadmap. We're going to follow the life of a meta-analysis from beginning to end, how studies are searched and selected, how results are pooled, how uncertainty is quantified, and how we assess whether the whole product is trustworthy. There's a lot of ground to cover, but we'll keep it practical and clinically grounded throughout. Let's start with the most basic question. What exactly is a meta-analysis? Systematic review and a meta-analysis are related but distinct. The systematic review is the whole process, the structured literature search, the inclusion-exclusion criteria, the critical appraisal. The meta-analysis is the statistical step at the end where you actually pull the numbers. You can have a systematic review without a meta-analysis if the studies are too different to meaningfully pool, but every meta-analysis should be embedded within a systematic review. The power of the meta-analysis is simple: more data, more precision. A single RCT of 80 dogs might give you an odds ratio with a confidence interval from 0.3 to 1.4. Pull 5 such studies and suddenly you have 400 dogs and a confidence interval from 0.5 to 0.9. That's a meaningful improvement in precision if the studies are compatible. And that if is everything. PRISMA flow diagram shown on the right is the first thing to look for when you open a systematic review. It shows you the attrition of studies at each stage, how many records were identified, how many were screened, and crucially, how many were excluded at each step and why. This transparency matters. If a researcher starts with 1,800 studies and ends up with 6, you want to know exactly what happened to the other 1,794. Were they excluded for legitimate reasons? Wrong species, wrong outcome, no control group, or were criteria applied inconsistently? The inclusion and exclusion criteria should have been defined before the search. If they were modified after seeing the results, that's a red flag. It introduces the same kind of bias as p-hacking in a single study. Let's go deeper on forest plot reading because there's more here than most people extract. Box size. The larger the box, the more weight that study carries in the pooled estimate. Weight is typically driven by study precision. Larger, tighter studies get more weight. Subgroups. Many modern forest plots divide studies into clinically meaningful subgroups by species, breed, dose, disease severity. Each subgroup gets its own mini diamond. This helps you see whether the treatment effect is consistent across different populations or whether it's really only effective in a specific subgroup. The key visual question is, do the study confidence intervals overlap substantially? If they do, the studies are consistent. If some CIs barely touch or don't overlap at all, you're looking at heterogeneity. And the next slide is critical. Heterogeneity is the central challenge of every meta-analysis, and understanding it separates sophisticated readers from superficial ones. I-squared tells you what proportion of the variation across studies is due to real differences between them, not just sampling error. Low I-squared means the studies are measuring essentially the same thing. High I-squared means they're measuring subtly different things. maybe different doses, different populations, different outcome definitions. This is where fixed and random effects models come in. When studies are homogeneous, a fixed effects model is fine. It assumes all studies share one true underlying effect and just estimates it more precisely. When studies are heterogeneous, a random effects model is more appropriate. It acknowledges that different true effects exist across study context and models that variation explicitly. The result is a wider confidence interval, which is more honest about the uncertainty. And always check which model was used and whether it matches the level of heterogeneity. When I-squared is high, the next question is, why? What is it about these studies that makes them disagree? The approaches to answering this are subgroup analysis and meta-regression. In a subgroup analysis, you divide the studies by some clinical or methodological variable, say species, drug dose, or risk of bias, and pool within each subgroup. If heterogeneity disappears within subgroups, that variable probably explains the disagreement. Meta-regression goes further, modeling how a continuous moderator variable, like mean age or dose, predicts the effect size across studies. But here's the critical warning. These analyses are exploratory. They are not pre-specified hypothesis tests. They generate hypotheses for future research. If a subgroup analysis shows the drug only works in large breeds, that's interesting, but it needs to be confirmed in a prospective study before you change your practice. Publication bias is one of the most insidious threats to meta-analysis validity, and the funnel plot is our tool for detecting it. The logic is elegant. Large studies are expensive and tend to get published regardless of result. Small studies only tend to get published when they show a positive result, because negative small studies get filed away. So if you plot odds ratio against standard error, a symmetric inverted funnel suggests an unbiased literature. An asymmetric funnel with studies missing in the lower left, where small negative studies would be, suggests publication bias. Look at the two funnel plots on this slide. The left one is symmetric, reassuring. The right one has a gap in the lower left quadrant. Small studies with odds ratios below the pooled estimate are conspicuously absent. Egger's test provides a p-value for this asymmetry, but it requires at least 10 studies to have meaningful statistical power. With fewer studies, rely on visual inspection. It is the internationally accepted framework for rating the quality of evidence from a systematic review, and is becoming increasingly common in veterinary literature. The 5 grade domains map directly onto the concerns we've been discussing throughout this series. Risk of bias, were the included studies well-designed RCTs or poorly blinded case series? Inconsistency, is I-squared high? Indirectness, was a study done in a different species or using a surrogate endpoint that may not reflect the outcome that matters clinically? Imprecision, is the CI still wide after pooling? Publication bias, is the funnel plot symmetric? Each concern can downgrade the evidence from high toward very low, but evidence can also be upgraded. For example, if the effect is very large and biologically plausible, that increases confidence even from observational data. When you see a meta-analysis that includes a grade summary table, that's a sign the authors are being transparent about the limitations of their evidence. Take it seriously. Before we get to the case, here's your practical checklist for evaluating any meta-analysis you encounter. First, the PRISMA diagram. If it's missing, transparency is already compromised. Second, clinical compatibility. Even if the statistics worked, if one study used dogs and another used cats and another used rabbits, the pooled estimate may be biologically meaningless. Third, heterogeneity. I squared above 75% with a fixed effects model is a major red flag. The model is ignoring real variation. Fourth, the pooled confidence interval. A statistically significant pooled result can still have a CI that barely clears the null or an effect size that's clinically trivial. Apply the same judgment you would to any single study. And the two red flags at the bottom are worth highlighting. A pooled estimate that's significant, even though most individual component studies are not, is arithmetically possible but should prompt scrutiny. It may reflect publication bias or subgroup pooling artifacts, and if all the studies come from the same research group, the independence assumption of meta-analysis is violated. Let's work through the case question systematically using everything we've covered today. The pooled OR is 0.44 with a CI of 0.31 to 0.62. That CI doesn't cross 1 and represents a 56% reduction in odds of vomiting. The direction and magnitude look clinically meaningful. But now let's apply our checklist. I squared is 68%, moderate to high heterogeneity. A random effects model was appropriately used, which is good, but that 68% means the studies are not telling a fully consistent story. We need to understand why they differ. The funnel plot asymmetry. Egger's P equals 0.09, not statistically significant at 0.05, but with only 9 studies, this test has limited power. The slight asymmetry is worth noting. There may be small negative studies that weren't published. The true effect could be somewhat smaller than 0.44. Grade, moderate. This means there's at least one serious concern that kept it from being high. Maybe some studies had unclear blinding or the CKD populations varied in stage and management. The subgroup finding is interesting. Early stage CKD shows a larger effect, but remember, subgroup analyses are hypothesis generating. This should prompt a dedicated prospective study in early stage CKD rather than immediately changing practice protocols. What questions would I ask before recommending maropitant? I'd want to know what CKD stage were the cats in the majority of the studies? What doses were used? Were there any safety signals? Maropitant has renal excretion considerations. And does the moderate quality rating reflect blinding concerns that could inflate the benefit? The bottom line, this is reasonably supportive evidence for maropitant in CKD-related vomiting, but with genuine uncertainty. Use clinical judgment, consider the individual patient's disease stage, and stay alert for emerging evidence that clarifies the heterogeneity. Sum it up. A meta-analysis is a powerful tool. It's the best summary of a body of evidence we have, but it's not infallible. The validity of the conclusion depends on the quality of the included studies, the appropriateness of the pooling method, and the transparency of the process. Your framework every time you read one. Check the PRISMA diagram for selection transparency. Inspect the forest plot for consistency and read the subgroups carefully. Look at I-squared and confirm the model choice matches. Examine the funnel plot for publication bias. Read the grade assessment to calibrate your confidence, and always apply clinical context. A pooled OR of 0.44 in a heterogeneous population of cats with CKD means something different for your specific patient in front of you than it does as an abstract statistical summary. Meta-analyses inform your decisions. They don't make them for you. That remains your job.